Welcome to the Deep Dive. We're here to help you make sense of your sources and get truly informed.
And today we're tackling a really big one, a challenging topic for sure.
Yeah, we're looking at the blueprints, you could say, for modern healthcare and education institutions.
Specifically, we're comparing two figures, John D. Rockefeller in the U.S. and Dr. T.M.A. over in India.
Separated by time, by geography, but setting up systems that, well, they look remarkably similar in some key ways. This mix of philanthropy, but also hyper-efficiency, and crucially, profit.
Right, and that's the paradox we really need to get into.
Yeah.
I mean, both men are often celebrated. They built huge, needed institutions, education, medical care.
Absolutely necessary infrastructure.
But what our sources, and we're drawing on academic work, investigative pieces, legal analysis, what they suggest is that these models, maybe because they were rooted in like rapid expansion and commercial thinking, they've ended up entrenching some deep inequalities and maybe even compromising the actual quality of care.
Leading to what, some are calling a broken system globally.
It's a strong claim, but the evidence needs examining.
So for you listening, here's the roadmap. First, we're going to dive into Rockefeller, how his obsession with industrial efficiency coming straight out of Standard Oil.
And his petrochemical empire.
Right. How that essentially shaped the modern American medical system. High cost, standardized, drug-focused.
Then we'll pivot. We'll look at Dr. T.M.A's model in India, which was different. It was more grassroots, fee-based.
But we need to unpack how that model, even though it filled gaps initially, kind of institutionalized commercialization, often behind this screen of charity.
Making medical school, for instance, basically unaffordable for huge swaths of the population. Only the wealthy could really access it.
And finally, the really critical part, connecting these threads. This commercialization, one top-down, one more bottom-up, connecting it to the consequences we see now.
Consequences like a huge doctor brain drain from India, systemic failures in public health.
And the one that's truly terrifying, antimicrobial resistance, superbugs.
Yeah. It's a story, really, about system design, how profit motives, even maybe unintentionally at first, spanning a century across continents, are now contributing to this massive health threat.
Okay, let's start with Rockefeller. Because his move into philanthropy, it wasn't just like a sudden burst of altruism, was it?
No, the sources suggest it was very much driven by that same industrial logic he used to build Standard Oil. Efficiency, control, scale.
Well, the scale was just unprecedented back then.
Totally. 1902, he sets up the General Education Board, the GEB. The initial donation was $1 million.
Which is, what, over $33 million today? Huge money.
The biggest single philanthropic donation in the U.S. at that time, yeah. And it was targeted higher education, medical schools, especially trying to build things up in the South.
But like you said, it came with strings attached, or at least a very specific philosophy.
An explicit one. Straight from the efficiency playbook. Rockefeller wasn't really funding education for, say, critical thinking or academic exploration for everyone.
No, it was about productivity.
Exactly. The GEB's stated philosophy was pretty clear. Poor children should be trained as workers. Efficient, productive workers. Not necessarily thinkers or academics.
It's applying factory logic to human potential, essentially. Standardization, predictable output.
It's quite something when you think about Rockefeller's own life, right?
Uh-huh.
Building this massive, ruthless empire.
Pushing competitors.
Yeah, consolidating power globally. And then he's expected to have, compassion and nuanced opinion about educating kids whose lives were completely different from his.
So he just applied what he knew? Efficiency. Train the lower classes to run the factories, his factories or someone else's.
And that mindset, that industrial approach, it didn't just build schools. It left a really lasting mark on how we measure people in education.
Standardized testing, that's where this connects.
It's a direct line, according to the sources. The GEB was a major funder for psychologists like Louis Terman and Robert Yerkes.
And these guys weren't neutral scientists.
Yeah.
The sources are clear on this.
No, they were staunch eugenicists. They believed intelligence was fixed, measurable, and that you could, and maybe should, sort populations based on it.
Which sounds pretty chilling today.
It does. And their work, funded partly by the GEB, was key in developing those early IQ tests used to classify U.S. Army recruits during World War I.
A massive experiment in population sorting.
Exactly. And that methodology, that framework, the whole idea of large-scale standardized testing, heavily backed by GEB money and influence, that directly paved the way for things like the SATs.
So the drive for efficiency didn't just standardize what was taught, it standardized how we measure potential.
And created a tool, maybe unintentionally, maybe not, that sorts kids by class. It disadvantages poorer kids, privileges those who can afford the prep, the coaching.
It's efficiency reinforcing the economic hierarchy. Still happening today.
And this same industrial mindset, this push for standardization and control, it very quickly moved beyond general education and right into medicine.
Okay, so how did that happen? The sources talk about 1910 as a key moment, the medical monopoly kingpin idea.
Right. This followed some influential studies, particularly one commissioned by the Carnegie Foundation. Rockefeller saw the findings, saw the opportunity, and heavily funded the shift that followed.
What was medicine like before this shift?
Much more diverse, actually. You had lots of low-cost options. Homeopathy was common, natural remedies, botanical medicine, things that were generally accessible, didn't always need expensive doctors or hospitals.
And the shift was
Towards what we call allopathy, the system we largely have today.
centralized, high costs.
Exactly. Based on synthetic drugs, requiring licensed physicians trained in specific ways, centralized hospitals, long residencies, expensive equipment.
And this allopathic model just happened to align perfectly with Rockefeller's business interests.
Well, that's what the sources strongly imply. Think about it. Where did Rockefeller make his fortune? Petrochemicals.
Right.
Synthetic pharmaceuticals often come from petrochemicals, or rely heavily on that industry. The new medical system needed synthesized drugs, lots of them. It needed hospitals, technology, all high-cost inputs.
So it's like vertical integration almost. Fund the system that demands the products your other businesses supply.
It looks that way. Engineer a system where doctors are trained primarily to prescribe these synthetic, often expensive drugs. You create a guaranteed, ongoing, profitable market.
It's quite a business strategy. Maybe not great for affordable healthcare, but brilliant for business.
And the sources argue this legacy persists. Why do doctors today get intense training on pharmacology, but often very little on, say, basic nutrition or preventative health or low-cost alternatives?
Because the system was structured that way from the start, to prioritize the most profitable inputs.
That's the argument. Standardized care around the things you can sell. Efficiency, but for profit.
Okay, that picture of engineered efficiency, top-down control, it sets the stage perfectly for looking at the Manipal model in India. Because that story starts quite differently, doesn't it?
It really does. While Rockefeller was using existing industrial capital, Dr. T.M.A.'s story is more about grassroots innovation, at least initially.
Tell us about him. He founded the Manipal Group.
Yes, and internationally, it's often cited as this case study in social innovation. He managed to mobilize resources locally, often through small community donations initially, to build educational institutions, using a fee-based model.
And he was meeting a real need, right? Post-independence India, the government just didn't have the capacity to build enough medical and technical colleges.
Absolutely. There's a huge gap. So Peyo's approach, this sort of private philanthropy-first model, it expanded rapidly. It built things the public sector couldn't, using private money, private fees.
But that's where the complexity starts. When this private fee-based model starts to scale up.
That's when the lines get blurry. The sources describe this widespread trend emerging in Indian medical education, following the Manipal example. Private colleges started charging, well, exorbitant tuition and capitation fees is the phrase used.
Capitation fees, like a large upfront payment just to get a seat?
Exactly, on top of tuition, which meant, realistically, only the very affluent could afford medical training in many of these places.
And how did they manage this while often being registered as charities or trusts? You mentioned a legal facade.
This is really the crux of it. Many sources argue that a lot of these private colleges function purely as businesses, but they use their legal status often as a charitable trust, as a kind of shield.
To hide commercial operations.
Essentially, yes.
Yeah.
To disguise what are really commercial ventures generating huge revenues from these high fees, from seed sales. Because they're trusts, the profits don't get taxed like corporate profits. They get reinvested.
Into building more colleges, more hospitals, buying land.
Exactly. Expanding the empire, increasing its valuation and influence, all under the banner of charity or education. It's a way to maximize revenue while keeping the philanthropic image.
Leveraging the massive demand for medical seats. And this wasn't just happening in a vacuum. Policy and legal decisions helped shape this.
Hugely. That 2002 Supreme Court case, T.M.A. Pay Foundation v. State of Karnataka, is fundamental here.
What did that ruling do?
It basically affirmed the autonomy of private, unaided educational institutions, gave them significant control over their admissions process, and, critically, their fee structures.
So they could set their own fees.
Pretty much. Now, the ruling did include some language saying that profiteering is not as yet accepted in Indian conditions, but that became a bit of a loophole.
How so?
Well, institutions could argue they weren't profiteering, they were just charging fees necessary to cover costs and generate a reasonable surplus for growth and maintaining quality.
And reasonable surplus can be interpreted quite broadly, I imagine.
Precisely. That autonomy granted by the court really turbocharged the trend of fee commercialization across the whole private education sector in India.
And this allowed other groups, maybe religious or caste-affiliated organizations, to copy the Manipal model.
Yes, it created a template. Rapid expansion using high-fee models became the norm for many private players wanting to get into medical education.
And the system has continued to evolve towards more open commercialization.
Definitely. Policy changes, especially since around 2016, have made it even easier. Now, even registered companies, not just trusts, can legally operate medical colleges for profit. It's basically normalized and legalized the trend Pi's model initiated decades ago.
So you trace this line from Pi, the local innovator,
To his grandson, Ranjan Pai, building a personal fortune from this educational base.
all the way to global finance stepping in. Singapore's Temasek buying a majority stake in Manipal hospitals.
It shows the full transition, doesn't it? From a community-focused, maybe philanthropic idea into a massive, globalized corporate healthcare madness,
Yeah.
where efficiency and expansion metrics are likely paramount.
And the human cost of getting that initial medical degree in this high-fee system.
It's immense. The sources talk about the emotional and financial stress on families, people going to catastrophic debt, selling land, taking huge loans just to pay these fees, all while the institutions maintain this philanthropic narrative.
That debt burden must shape the choices doctors make later on.
Absolutely. If you start your career hundreds of thousands of dollars in debt, you're inevitably pushed towards higher-paying specialties or working overseas. You simply can't afford to work in low-income areas or the public sector for long. The system basically extracts wealth up front to fund its own growth.
Which leads us right into the consequences. This profit-driven education model seems to be creating a healthcare system in India that's facing multiple crises.
Yeah, the fallout is visible on several fronts, starting with the quality of the education itself.
Because they expanded so fast.
Right. The number of medical seats shot up, sometimes doubled, to meet demand and generate revenue. But the infrastructure, the faculty, the clinical training opportunities, they often didn't keep pace.
So you get doctors potentially graduating with less hands-on experience.
That's the concern raised in the sources. Inadequate clinical exposure, poor faculty-student ratios, leading to questions about overall standards.
It's ironic, then, that even with all these new, shiny private colleges, many still consider the older public teaching hospitals better for actual training.
It is ironic. The public hospitals might be overcrowded, under-resourced, but they often have the sheer volume of patients, the variety of cases that provide crucial hands-on experience. Some of the private colleges, focused on attracting high fees, might lack sufficient patient flow for robust training.
They prioritize the appearance over the substance, perhaps.
The metrics might favor building impressive facilities over ensuring deep clinical immersion. That's a risk in a commercialized system.
And then, after graduation, comes the exodus, the brain drain.
It feels almost inevitable, given the costs. Doctors graduate with huge debts, look at the low salaries and tough conditions in the Indian public sector, and then see opportunities abroad with much better pay and lifestyle.
Is there data on this?
Yes, a nationwide survey found that over 76% of Indian medical undergrads interested in going abroad cited better pay and lifestyle as a key factor. They need to recoup their investment.
But it's not just about money, is it? The reservation system also plays a role.
It's a complicating factor, definitely. India has a caste-based reservation system for government college seats, intended to promote equity. But if a student from a non-reserved category doesn't get one of those subsidized government seats,
Their only option might be the super expensive private route.
exactly, which then increases the pressure to earn big money, often abroad, to pay off the loans. The same survey showed that nearly 69% of students planning to leave India cited the reservation system as a factor influencing their decision.
So a policy designed for equity might inadvertently be pushing talent towards the commercial sector and then out of the country.
It's one of those complex, unintended consequences. The system ends up exporting doctors that India desperately needs, especially in rural areas, and the public system.
Which leaves the government hospitals in what the sources call dire straits.
Dire straits seems accurate. They're struggling with basics. Inadequate equipment, Sometimes unqualified staff filling teaching positions, issues with cleanliness, very low salaries that make it hard to retain talent.
You end up with this awful mismatch. The places with the most patients, the poorest patients.
Have the fewest resources, the lowest quality of care available. It's an inverse relationship between need and service.
And a big part of this is just chronic underfunding by the government.
That's a major factor highlighted. India spends only about 2% of its GDP on health. Compare that to 15% or more in many developed nations. That lack of public investment starves a system.
It affects everything: infrastructure, research.
Research is reportedly dying out in many teaching hospitals simply due to lack of funds. And you can't retain experienced doctors on those salaries.
Beyond the structural issues, this commercialization seems to be changing the very identity of being a doctor.
There's definitely a cultural shift noted. The traditional role of the physician as a healer, someone deeply trusted, is eroding. They're increasingly seen, or perhaps forced to see themselves, as healthcare workers.
Managed by metrics, like in any other industry.
Pretty much. Patients become clients or customers. Doctor performance might be judged on patient throughput, satisfaction scores tied to revenue. Professionalism starts to mean adopting business practices.
And the casualty is that human connection, the doctor-patient relationship.
It gets sacrificed for efficiency, for the bottom line. When medicine becomes industrialized, the focus shifts from healing the individual to managing the process. The healer gets replaced by the metric manager.
And this, tragically, brings us to the superbug crisis. If industrialization is the root cause, AMR antimicrobial resistance is perhaps the ultimate, most dangerous symptom.
It really is. AMR is flagged as a top global public health emergency. The projections are staggering, potentially 10 million deaths worldwide every year by 2050 if we don't get a handle on it.
More than many cancers, more than road accidents.
Exactly. And here's the direct link back to our discussion. The sources confirm that hospitals, drug companies, healthcare facilities themselves, they are major superbug hotspots and polluters spreading resistance into the environment.
The places meant to heal are actually breeding grounds for untreatable infections.
And it's largely driven by irrational prescribing of antibiotics, which again is fueled by the commercial pressures and systemic issues we've been talking about.
Okay, let's break down why doctors might be overprescribing. Patient demand is one factor.
Huge factor. Culturally, many patients now expect antibiotics for almost anything, even a common cold, which is usually viral. They see it as the standard of care.
And doctors feel pressured to give it to them.
Especially in private, commercial settings. They worry about patient dissatisfaction, bad reviews, losing business, or even litigation, though that might be less common. So they prescribe defensively to keep the customer happy, even if it's not medically sound.
Prescribing for satisfaction, not for science.
That's one part. Then there's direct commercial influence. Pharmaceutical companies still do a lot of promotion, and for smaller hospitals or clinics, selling antibiotics, especially intravenous ones, can be a significant income stream.
So there's a direct financial incentive to use more antibiotics.
In some parts of the system, absolutely. Usage patterns get warped when your revenue depends on selling the drugs.
And the third driver connects back to the education quality concerns. Lack of good diagnostics.
Yes. When doctors are rushed, or perhaps haven't had the best training in diagnostics, or lack access to good labs, they often fall back on empiric treatment.
Meaning treating based on symptoms, not a confirmed diagnosis.
Right. Using broad-spectrum antibiotics just to cover possibilities, or using quick diagnostic tests like urine dipsticks for UTIs, which can have high false positive rates, leading to unnecessary antibiotic use.
It's defensive medicine again, prescribing out of fear or lack of time or lack of resources or just to move the patient along.
And the consequences aren't some distant future threat. The sources say the post-antibiotic era is basically here. We're seeing resistance everywhere.
Like the New Delhi superbug.
That's a prime example. NDM1 resistance. It's already spread to over 70 countries. And worse, we're seeing resistance to our last resort drugs.
Like colistin.
Exactly. Colistin is supposed to be kept in reserve for the worst infections, but the resistance gene, MCR1, which can jump between bacteria, has been found in bugs like Klebsiella pneumonia in India.
And it travels easily. You mentioned tourists carrying it back.
Yeah, a Swiss study found 11% of tourists returning from India were carrying bacteria with that specific colistin resistance gene. It shows how interconnected this is. A problem fueled in one part of the world rapidly becomes a global threat.
Because if we lose antibiotics,
we lose modern medicine as we know it. Cancer treatments, organ transplants, major surgeries, even treating simple wounds, all depend on having effective antibiotics. It's an existential risk.
Yet the regulatory system seems unable to stop this spiral.
Yeah. It's described as dysfunctional. There are guidelines, sure, but enforcement seems weak or absent in many areas.
So bad practices continue.
Like prescribing irrational combinations of antibiotics, say Cipro plus amoxicillin. These cocktails increase side effects, cost more, and are terrible for driving resistance, but they still happen.
And the reserve drugs aren't being protected.
Not effectively enough. Carbapenems, another class of last resort antibiotics, are often used too early. Patients might get them in a secondary private hospital after failing initial treatment, even before a proper diagnosis confirms they're needed.
So the most precious drugs are being squandered.
While paradoxically, sometimes the powerful reserve drugs might be easier to obtain through questionable channels than older, safer, maybe less profitable antibiotics that should be used first line according to stewardship principles.
The market finds a way, driven by demand and profit, even if it leads to disaster.
It seems that way. The regulatory vacuum allows the commercial pressures to override good medical practice.
So bringing this all together, we've looked at Rockefeller's top-down engineering in the U.S., focused on efficiency, profit, standardization.
And Dr. Pai's model in India, starting grassroots, fee-based, but scaling into widespread commercialization and corporatization.
And both paths, though different in origin, seem to have led to systems where the business side, the metrics, the profit motive, it overshadows the core mission of healing.
That's the convergence. Both, perhaps unintentionally at first, created structures that ultimately compromise care quality, deepen inequality, and now leave us facing this shared, terrifying threat of AMR. It's a global problem with roots in these foundational models.
And tackling this crisis, especially in the Indian context described, it seems to demand more than just tweaking policies. It points to a deeper failure in governance, in planning.
It really does. It suggests a need to get back to basics, like systematic planning and quality control. Think about the Plan-Do-Check Act cycle from management science.
Plan, implement, check the results, act on the findings. A feedback loop.
Exactly. But the sources suggest that in Indian healthcare governance, the check and act parts are often missing. Big policies get rolled out the do phase driven by headlines, maybe.
But without rigorous follow-up, without checking if they actually worked or what negative consequences arose.
Right. The feedback loop is broken, so mistakes get compounded, problems fester. There's a lack of long-term measured planning based on actual outcomes.
So the solution isn't just building more expensive hospitals or training more highly specialized doctors within the same flawed system.
Probably not. The sources argue for a shift. Moving away from this hyper-specialized, doctor-centric, high-cost model that commercial education feeds, instead, empowering other professionals.
Like nurses, allied health workers.
Yes. Training and enabling them to deliver high-quality, affordable primary and preventive care, especially in underserved areas. Take some of the burden off the expensive, specialized end of the system. It requires a fundamental rethink of roles and delivery.
We've painted a picture of systems prioritizing profit and efficiency, arguably at the expense of patient needs, safety, and equity. Which brings us to our final thought for you, the listener. Something to chew on.
We're looking at a future where this efficiency drive reaches its perhaps logical conclusion. Predictions suggest that by 2030, maybe 90% of medical consultations could be handled by AI, not a human doctor.
Replacing the variable, maybe inefficient human element with a standardized, potentially more cost-effective machine.
So the provocative question is, if you take the human doctor out of the equation for most interactions, what happens to trust? What happens to that human connection that, historically at least, was seen as vital to healing?
Can you really trust an algorithm owned by a corporation in the same way you might trust a human physician you know, even if the AI is technically accurate?
And does this relentless pursuit of efficiency and technological solutions, which stems from the very industrial mindset we discussed with Rockefeller, end up sacrificing something essential?
We know from studies like in hospice care that when the aggressive medical interventions stop, patients often find a sense of meaning, a lost return.
So are we, in our drive for efficiency and profit in the main part of the healthcare journey, inadvertently sacrificing the emotional, the spiritual, the truly human needs of patients long before they reach the end? Are we optimizing the process but losing the purpose?
A profound question to consider, thinking about the systems that shape our health and lives. Thank you for joining us on The Deep Dive.